Dr. Torres, what are some of the complications with the lung transplantation procedure?
Tom, we would wish that all the lung transplants would move and happen very smoothly. But you're right. There are so many pieces in a lung transplant that something can go wrong, that something always will go wrong. But that doesn't mean that we are going to lose the organ. It only means that we had a complication, and we have to deal with that complication. This is a normal chest X-ray on a patient who underwent lung transplantation. And you can see beautiful organs. You have chest tubes on both sides draining fluid out of the chest, and the heart is in normal size right now. Patient is intubated, and this is what we like to see just after lung transplantation. Unfortunately, that's not always the case. The main complication that we see shortly after lung transplantation is what we call reperfusion injury. This is a chest X-ray of a patient who had a right single lung transplant, and you can see that, my God, he was better off with the native left lung. The right lung is all white out, infiltrates. Obviously, that lung is not working. Fortunately, we only did a right single lung transplant. So while we're fixing that right lung, the native bad lung is keeping the patient alive. And all and behold, this reperfusion injury over the next 48, 96 hours will get better to the point where most likely the patient will not have much of a sequelae from this injury. And this injury happens because when you take an organ out of their donor organ, you have to preserve that organ, and then there's time that occurs from taking that organ from the donor hospital until you put it into the recipient, and then you suture the organ, and then suddenly you put new blood into that organ. There are so many free radicals. There's blood, immune cells reacting with the new lungs, and all of that causes the blood vessels of the new lung to be leaky, and water, plasma, then sneaks into the lungs. And most of what you're seeing here is plasma inside the lung. And yes, basically the organ is drowning. So we have many techniques that we use to help that lung recover. After reperfusion injury, infections. The donor organ may have had an infection. But not only that, we're going to immunosuppress the patient significantly. And there are certain infections like viral infections that we all have in our body, but our immune system monitors and keeps in check. And one of those infections is CMV infection. And patients can develop CMV pneumonitis, and if not monitor and not control, the patients would die. But currently, we have good medications that can take care of these infections. We can develop fungal infections as our immune system is suppressed after lung transplantation, aspergillus, nocardia, infections that you need a good lung transplant team managing you, keeping an eye on things so that if these infections occur, you react to them and are able to save the patient. Whenever we talk about transplantation, we always talk about rejection. And again, having an episode of rejection doesn't mean you lost the organ. It just means your immune system is doing what it's supposed to do. Get rid of things that don't belong in that organ. And as much as we want that new lung to belong in that recipient, it really doesn't belong there. And your immune system has many ways of getting active and recognizing that organ. That's why our patients are on 3 different medications to suppress the immune system to attempt to get the immune system not to react to that organ. But sometimes our medications do not work the way they are supposed to at the levels that we're giving, and you can have acute rejection. You can see the infiltrates on the chest X-ray, and when you do a biopsy, you can see all those blue cells surrounding the blood vessels, and that's an episode of acute cellular rejection. The good thing is that we can treat these acute rejections. We give them steroids, and you can see the X-ray below where the infiltrates all resolve. And most of the time, that's the sequelae of an acute rejection. There are other mean things that can happen to our patients. They can develop what we call post-transplant lymphoproliferative disorder. If you look at that chest x-ray, there's a little knob next to the heart, and that was a lesion that we did a biopsy, and it was a PTLD post-transplant lymphoproliferative disorder, a type of lymphoma. Again, 15 years ago, this could have been deadly. We only would decrease the immunosuppression and hope that your immune system would clear it. Nowadays, we have antibodies that most of the time you give one-time antibodies and you can wipe out that type of lymphoma. Obviously, things can go wrong with the connections that the surgeons do, connecting the airways. And in the last pictures is adhesions, breakdown of one of those anastomosis connections of the airway, where the airway got infected and then suddenly it broke apart. And obviously, we have to take the patient to the operating room and repair that anastomosis. So there are many, many different potential complications that our patients can have and endure. The important thing is to remember, we have technology to help us through them. We have medications. And just because you had a particular complication, that doesn't mean you lost the organ. Sometimes we do, but most of the times we do not.
So many things could go wrong, and you have to do so many things right. Thank you for this fascinating look inside.
No, thank you, Tom. And remember, it's not just one person. You have a whole team of people helping these patients. It's a real multidisciplinary approach to caring for a patient.
Indeed. Thank you, sir.
Thank you.